Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anish Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about head and neck cancer with Dr. Zafar Sayed. Dr. Sayed is an assistant professor of surgery and otolaryngology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
Zafar, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
Yeah, sure. So I am currently a head and neck surgical oncologist at Yale, which means I specialize in disorders of the head and neck, basically tumors or other pathology that involves the area above the collarbones and outside of the brain. So I am an otolaryngologist by training, also known as an ear, nose, and throat specialist, and I have subspecialty training in head and neck cancer surgery specifically. So it's kind of a very large, wide field, very varied, and that's part of the reason I'm doing it. I think it's really exciting and fun.
Yeah. I mean, it's always interesting when I think about ENT surgery or head and neck surgery, that space between above the collarbone and outside of the brain actually has a lot of stuff in it. And the stuff that it has in it is varied. I mean, your nose is very different from your ears, is very different from your throat. So can you kind of give us a landscape of what all of these cancers of the head and neck are like, and, what kind of groups them together aside from their geographic area?
No, it's a great point. So we often joke that the head and neck is, it's very high value real estate, and a lot of what we do involves some of what is very basic to being human. So your ability to smell, your ability to talk, your ability to breathe and communicate verbally and express emotion with your face, all of that is in the head and neck. So head and neck cancer is really a catch-all term. And so we could be talking about skin cancers, for example, that affect that area where there's a lot of ultraviolet exposure, for example. We could be talking about endocrine malignancies like thyroid cancer, parathyroid disease. And then a lot of what we really mean when we talk about head and neck cancer has to do with mucosal cancers. Now, the mucosa is the lining that is kind of in the mouth, in the throat, in and around the voice box, in and around the sinus cavities. So tumors in those areas are often referred to as head and neck cancers. And most of the time, they are squamous cell carcinomas, but we see a varied number of tumors that can be from the salivary glands, for example, and certainly some soft tissue cancers like sarcomas. So again, it's a very kind of broad term, and we have to talk about specifics when we're talking about risk factors and treatment plans.
Yeah. I mean, because even when you're giving us kind of that high level list, you can imagine that different patients with head and neck cancers can have very different prognoses. I mean, I can imagine that somebody who has a fairly benign skin cancer, like a basal cell cancer that might occur on their cheek, might have a very different prognosis from somebody who has a really aggressive, soft tissue sarcoma. So can you kind of tell us a bit more about, kind of which cancer is the most common? Which do you see the most often? And maybe we can talk about each of these in turn, because I think as you say, each of them is going to be very different.
Yeah, you're absolutely right. So all of these tumor types are going to behave drastically differently depending on the tumor type itself and the location and obviously the staging. So when we're talking about head and neck cancer, I think it makes sense to focus mostly on squamous cell cancers. And squamous cell carcinoma accounts for probably greater than 90% of the mucosal cancers that we see. So again, voice box tumors, tumors of the throat, for example, and also can encompass some of the skin cancer that we see in high ultraviolet exposed areas of the face and of the scalp.
So Zephyr, that makes sense in terms of all of these being squamous cell cancers. And we know that squamous cell cancers, at least of the skin, are often associated with UV light. But you would think that squamous cell cancers of, for example, your voice box, those aren't exposed to UV light. So, can you talk a little bit about risk factors for these squamous cell carcinomas? I mean, it would seem to me that it's very different based on where exactly they occur.
Yeah, great point, and you're absolutely right. So the risk factors we do know are changing a bit. So if we look at 20, 30 years ago versus now, some of those risk factors are actually are changing. But historically, the two big ones that we always used to talk about and counsel patients about was tobacco use. So that could be cigarette smoking, that could be chewing tobacco use, and then also alcohol use. So frequent alcohol use with a tobacco history, those two really work synergistically to increase the risk of squamous cell carcinoma, especially mucosal squamous cell cancers. Now, in the kind of current modern era, over the years, we've been seeing a rising incidence of human papillomavirus associated cancers. And these are often throat tumors or oropharynx tumors that involve the very back of the tongue or the tonsil area. And we'd estimate right now that about 70% of those cancers are virus associated. So things are definitely changing a bit. We do have some less common risk factors that we'll often ask patients about. So if you come to our clinic and we do diagnose cancer or mucosal cancer, we may ask about things like, oral hygiene. What's your dental hygiene like? Or do you wear a denture, for example, that's causing local irritation or trauma to part of the mouth? So some of these less common risk factors are also at play.
So it's interesting that you mentioned the HPV or the human papillomavirus associated cancers. So very often when we're talking about these cancers, we think about cervical cancer and we think about them being sexually transmitted. In the oral pharynx, is it also sexually transmitted? And when we think about HPV vaccine, we often advise that for women and girls to prevent cervical cancers. But can you talk a little bit about the fact that both girls and boys and people of other genders too all have throats? And so the rationale for HPV vaccination regardless of gender?
Yeah, so HPV has really been in the news lately. There's a couple high-profile cases, A-list male celebrities like Michael Douglas and Val Kilmer have been quite public about their HPV-related cancer diagnoses. And what we're finding is that although, women have been quite familiar with HPV due to routine pap smears and cervical cancer screenings, we're finding that men can also undergo HPV infection, and this is sexually transmitted, usually due to oral sex. But that virus can then take up in the tonsil tissue, which is located again in the back of the throat. And a viral infection that occurs even decades prior can ultimately lead to some DNA mutations that eventually lead to squamous cell cancer. And it's really important for us to try to identify these specific cancers that are HPV related because the prognosis and the treatment algorithms can sometimes be a little bit different. And they're certainly changing. And I think over the next 5 to 10 years, we're going to be kind of adjusting how we treat these cancers. They tend to be very treatable. They tend to respond very, very well to some of the radiation-based treatments, for example, and some of the systemic therapies. So it's important for us to identify that and also talk to patients about primary prevention. You kind of touched on the vaccine. I'm happy to get into that.
If I heard you right, you said 70% of these squamous cell cancers now are HPV associated. And so if there's a way that we can prevent getting those, it sure is good to know about it. So why don't you tell us more?
Yeah, sure. So of course, early detection is always important. So we will, I'm sure at some point during this conversation, hit on what symptoms should we be looking for? But Gardasil is really a HPV vaccine that is meant to hopefully prevent HPV-related tumor formation. There are about 9 HPV high-risk subtypes that are included in that vaccine, including type 16, which is very commonly associated with HPV-related cancers. And that vaccine really can now be administered to individuals as young as 9, and both men and women up to the age of 45. And so the thought is, even if you have been exposed to HPV, let's say in your adolescence or as a young adult, you still may come into contact with a high-risk subtype at some point down the line. So initially, I think the FDA was a little bit more narrow about the age range, and now that's been extended from the mid-20s to the mid-40s. And so for individuals who are in that age group, it's always worth a discussion with your primary care doctor, or if you have an ear, nose, and throat doctor. I think many providers are now recommending to do that. I think if you get the vaccine as an adolescent, it is currently 2 shots or 2 vaccinations spaced apart, somewhere between 6 to 12 months, I believe. And over the age of 15, there are 3 vaccinations required. But it has been found to be, very effective if you get this ahead of time at preventing these cancers.
So I often think about that, and I think it's great that the age range has been expanded, because you can imagine that if you're just outside that age range, when the vaccines got approved, you're like, dang, I could have had a preventative strategy against some pretty nasty cancers. But what about the people who might be even outside of the mid-40s? Say somebody in their early 50s. They haven't gotten vaccinated, but they're not eligible. Should they be?
Yeah, I think this age range may continue to grow, may continue to expand. Again, no matter how stable your relationship is or where you're at in your life, there could still be a small possibility of coming into contact with the high-risk HPV strain. And we found that the vaccine is very safe. And so even for immunocompromised patients, it is usually safe to administer the vaccine, provided you're cleared by your medical provider. So I think this range is going to increase. I think what we're hoping is to see vaccination rates go up. Obviously, this is most effective if we can have young children between the ages of 11 and 12 vaccinated prior to sexual contact. But right now, vaccination rates are still quite low. And so there's a big push to making sure that the young individuals are getting vaccinated prior to exposure. And then, of course, thinking about folks who may be a little bit older but still aren't quite out of the woods.
And just so that we're clear, some vaccines, for example, COVID, doesn't really prevent you from getting COVID. It prevents you from dying from it, right? It reduces the symptomatology of COVID. But the HPV vaccine, my understanding from what you're saying is it actually prevents you from getting these cervical cancers. Is that right?
Correct. Yeah, it's gonna prevent high risk subtypes from leading to cancer. So hopefully we never get infection in the first place, and certainly don't get a latent infection that then causes these DNA mutations. So that includes, as you said, cervical cancers, anal cancers, and also oropharyngeal cancers or throat cancers.
Fantastic. We're going to pick up this conversation right after we take a short break for a medical minute. Please stay tuned to learn more about the care of patients with head and neck cancers in honor of Head and Neck Cancer Awareness Month with my guest, Dr. Zafar Sayed.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their prostate and urologic cancers program is comprised of a team dedicated to managing the diagnosis, evaluation, and treatment of urologic cancers, including testicular cancer. SmiloCancerHospital.org. It's estimated that over 240,000 men in the U.S. will be diagnosed with prostate cancer this year, with over 3,000 new cases being identified here in Connecticut. 1 in 8 American men will develop prostate cancer in the course of his lifetime. Major advances in the detection and treatment of prostate cancer have dramatically decreased the number of men who die from the disease. Screening can be performed quickly and easily in a physician's office using two simple tests, a physical exam and a blood test. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and its Milo Cancer Hospital, where doctors are also using the Artemis machine, which enables targeted biopsies to be performed. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anees Chagpar, and I'm joined tonight by my guest, Dr. Zafar Sayed. We're talking about the care of patients with head and neck cancer. And before the break, we were talking about the fact that the head and neck is, as Dr. Sayed says, prime real estate. There's a lot of stuff in the head and neck. And many of these cancers are what we call squamous cancers, coming from the lining of the head and neck. And up to 70% of these are related to HPV. And we were talking about the fact that HPV vaccination can actually prevent these cancers. So how cool is that? The good news is that these vaccinations have now been expanded in terms of not simply being for children, 9, 10, 11 years old, although certainly that would be the ideal time to get vaccinated. But if you weren't vaccinated then, you still have the opportunity to get vaccinated well into your 40s. But Zafar, I want to pick up the conversation now to talk about the people who may not have gotten vaccinated and so who may now have developed a cancer. We talked a little bit before the break about the fact that some cancers show up on the skin, and arguably those would be ones that we can see. But the head and neck, everything between the collarbone and outside of the brain, includes a lot of areas that we can't see. So can you talk a little bit more about how you know kind of the warning signs, the signs and symptoms of head and neck cancers, and when you should see a doctor?
The head and neck is, again, responsible for your ability to speak, your ability to have a clear voice, your ability to breathe, your ability to swallow. So changes in any of those functions can sometimes tip us off to a tumor in those locations. So, for example, if you have a tumor of your vocal cord, you may notice, hey, my voice has been a little bit hoarse for the last couple months and it's not getting better. Or if you had a tumor of the base of the tongue or the tonsil, one of these HPV-related cancers, your voice could sound muffled. You may have some sensation that there's something in the throat, or swallowing solid food or liquid food may just feel different and may be a little bit more difficult. So those symptoms can be subtle, and they could, again, tip you off that maybe you need to at least have an ear, nose, and throat doctor or a head and neck surgeon examine you to ensure there's nothing going on. But oftentimes we have patients come into the clinic who have developed a neck lump or a mass. And often these neck masses are non-tender, meaning they're not really symptomatic, they're not painful, there are no skin changes, but you just sort of notice something either on a self-exam, or for men especially, when you're shaving, you pick up something that is actually an enlarged lymph node. And so I tell my patients, or at least when we're talking to the public at these screening events, that a non-painful neck mass that hasn't gone away in several weeks really should alert you to talk to your physician. And what we find when we evaluate these neck masses is, occasionally we're dealing with metastatic squamous cell cancer that has spread to a lymph node, and that needs to be diagnosed and obviously worked up. So that can also be a common presenting sign.
Another thing that you had mentioned when we were talking about risk factors beyond HPV, you had mentioned smoking and drinking. But the other thing that you mentioned as less common was if you've had irritation from a denture. And I'm just thinking about the older adults in my life who do wear dentures. And, are there things that they need to be watching out for?
Yeah, and again, this isn't a very common risk factor, but it's not unusual for us several times per year to have a scenario where someone may have an ill-fitting denture. Maybe it fit great initially, but as the bones of the face, as the bone kind of resorbs as we get older, that fitment may not be great. And so now you've got this, prosthesis or this foreign body in the mouth that's constantly rubbing up against the tongue, for example. And what you see is the lining in those areas where there is that chronic irritation can change. And that change is called dysplasia, which is kind of precancerous or atypical cells that are on their way to becoming cancer. And so clinically, as a physician, when we look in the mouth, we're looking for white patches that may be developing around some of this irritation. Those white patches are called leukoplakia and usually tip us off to some really early dysplasia that may need a biopsy and may need a diagnosis. If that process continues, what we would see is that leukoplakia can sometimes transform or transition to a red patch, which is called erythroplakia, and eventually that erythroplakia can transform into cancer in a higher percentage of cases. Now, a chronic white or red patch that you notice in the mouth that isn't going away, a canker sore, for example, an ulceration that could be painful, that's not healing over several weeks, even though you've removed irritants, that could be contributing. Those sort of findings might warrant you at least talking to, your dental provider or your primary care provider about next steps.
And I can imagine that along with those ulcerated canker sores, might be things like, if you have a sore in your mouth that starts bleeding, or in your nose, if you have nosebleeds, those might also be things that trigger some alarm bells. Is that right?
Yeah, absolutely. For nosebleeds especially, very common in the wintertime with the dry air for patients to come in with nosebleeds, and they're usually minor and something that we can easily take care of. But if you have persistent nosebleeds, especially from just one side of the nose or one nostril on a consistent basis, that again could be a tumor, for example, in the sinuses or in the nasal cavity that needs workup. So there's a number of different symptoms we could be dealing with, but the key thing is to be vigilant and make sure you bring up new symptoms that are concerning to you to your doctor.
And so then what happens? Let's suppose, you've either noticed a lump in your neck or you've noticed that, you're not swallowing as easily as you used to, or you have these persistent nosebleeds, and you finally get up the nerve to go to the doctor. I mean, I think that in part, some people wait a while because, well, number one, we don't like seeing doctors. And number two, we tend to be a little bit nervous about what exactly happens next. So demystify it for us. What does happen next?
Yeah, sure. So for somebody who comes in the door, who's at our clinic and comes in with, new symptoms in the head and neck, we're going to ask for a really thorough history. We want to know, when did your symptoms start? Tell us more about the severity. Does anyone in the family have similar symptoms, or is there a known history of head and neck tumors or head and neck cancer? So we're going to get a really thorough history. We're going to ask a lot of questions that relate to speaking and swallowing and breathing, for example. Typically during an ear, nose, and throat or head and neck surgery exam, as part of the physical exam, in order to get a good look at the voice box and a good look at the nose and the back of the throat, we do some endoscopic procedures called flexible laryngoscopy or nasal endoscopy. And this involves taking a really small flexible camera, basically a small tube that we, through the nose, go in and take a look at all of these sites. So that procedure, if you can call it that, is quite short, may take under a minute. It is not typically painful. It might be a touch uncomfortable, obviously, but we do anesthetize the nose with a little topical lidocaine, and it's usually very well tolerated. So if you're coming in with the symptom, you should expect a thorough history, a thorough physical exam. If, for example, you have a lump or a mass somewhere on the face or neck, we may recommend a biopsy. Oftentimes, that's a minimally invasive biopsy that's done under ultrasound guidance with a very small needle. These needles are smaller than what are typically used to draw blood, and we would just take a few cells from the mass for testing. So all of that can typically be done during a routine visit, and based on results, we then determine, okay, do we need to get additional scans, for example, like a PET scan or a CT scan, or is there something here that needs a more formal exam in the operating room under anesthesia so we can better assess these areas?
So let's say it is cancer, And you had mentioned that you might need to do more scans or more investigations. Presumably that is to see whether or not this has spread outside of the head and neck. Is that right? And if so, how common is it that this cancer has spread outside of the head and neck?
Yeah, the cancer staging is going to be done primarily with CT scans or PET scans, for example, that are looking head to toe to identify spots, typically in the lungs or the liver or the bone, that may be suspicious for distant disease, that is, cancer that has spread outside of the head and neck. We're fortunate in that most head and neck cancers have a low risk of distant disease. It's typically 5% or less for the majority of patients. However, there are certain risk factors. So, for example, if you have a larger tumor, if the tumor is more deeply invasive into surrounding structures, if there are multiple lymph nodes involved in the neck, especially low-lying lymph nodes near the collarbone, all of this can tip us off that a patient may have a slightly increased risk. But we try to identify that on our staging scans. Occasionally, a patient, if they have a suspicious nodule in the liver or in the lungs, for example, may get a biopsy of those sites as well to confirm that diagnosis, because that can sometimes radically alter what we're recommending in terms of treatment.
Okay. But if the vast majority of these head and neck cancers are confined to the head and neck, and hopefully are found early, then that sounds like that would be a good thing in terms of prognosis. So can you tell us, A, is it a good thing? And how good is it if you can find your cancer early and it's confined to the head and neck? And B, what does treatment look like?
Yeah, so typically if the cancer diagnosis is staged in such a way that we are confined to the head and neck, we are typically going to recommend curative intent treatment. That is, whatever we're recommending, we're hoping to eradicate the disease and eradicate the tumor. We work in head and neck really in a team-based approach. It's very multidisciplinary, and the head and neck surgeon is certainly part of that group, but we almost always, for advanced stage cancers, will get you to see a radiation specialist or radiation oncologist and also a medical oncologist. The medical oncologist is a specialist who can administer systemic treatments. So those may be chemotherapies or more recently immunotherapies or targeted systemic therapies. So we work as a group to identify, based on your tumor type, based on the location, the type of cancer you have, maybe even some molecular markers in your tumor, what's the best option for you in terms of treatment. And then here at Yale, we also have a number of clinical trials that are looking at some of these diseases as well, which patients may be a part of.
What is the prognosis for people who are being treated with curative intent?
The prognosis, especially for HPV-related cancers, again, which we're seeing a higher incidence of, is actually very, very good. And there's a big push towards de-intensifying or de-escalating our treatments in such a way that we can really preserve speaking and swallowing function. And we are looking into starting to decrease potentially radiation doses and also administer new forms of systemic treatment like immunotherapy, which can be very effective in certain cases.
Dr. Zafar Sayed is an assistant professor of surgery and otolaryngology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.